All right. So my name is Samuel. I work with the University of Ghana School of Public Health, and I'm supposed to be moderating this session. So we're inviting our first speaker. Our first speaker is Miss Elizabeth, and she's presenting on a study on rate of sexual violence and post-exposure prophylaxis initiation among rape survivors in Plateau State in Nigeria. She is a public health specialist with a dual degree in physiology and public health, and has been doing a lot of work in the area of public health. So can we listen to our first speaker? Thank you.
Thank you, sir.
You have 10 minutes to do the presentation.
Okay.
We'll take all the speakers and then we can do the questions.
Thank you very much. Good morning, everyone. Thank you all for being here. My name, once again, Elizabeth Isah. I'm with APIN Public Health Initiatives of Nigeria. Sorry, the slide. Thank you. So the title of my study is on the rate of sexual violence and post-exposure prophylaxis initiation amongst rape survivors in some selected hospitals in Plateau State, Nigeria. They are my co-authors. And we'll be looking at the outline. First, the background, overview of post-violence care in Plateau State, the intervention approaches, objectives of the study, research methods, findings, conclusion, recommendation, and acknowledgement. Next slide, please. So according to UNICEF, sexual violence is defined as a form of sexual abuse or sexual exploitation of a person. And it has been seen to be a potential driver of HIV infection in sub-Sahara. UNICEF estimates that 1 in 4 girls and 1 in 10 boys get to experience sexual violence before they turn 18. Another study, which was done in a university in Nigeria, also showed that out of the respondents, it was a qualitative study, 153 women within the age of 17 to 24 years had experienced sexual violence, and that only 13% of them had access to any form of post-violence care. So despite the high prevalence of sexual violence in Nigeria, access to PEP is still limited due to a lot of factors. Next slide, please. So the overview of post-violence care in Plateau State. APIN Public Health Initiative, being the lead IP in Plateau State, provides support in the HIV program as well as post-violence care and PEP initiation to clients who are in need of these services, with support from PEPFAR through CDC. So where do we provide these services? The healthcare facilities, The healthcare facilities. Service providers are the medical personnel, be it the post-violence care focal persons, be it the lab persons who test for HIV and STI as well, and the pharmacists, won't forget them, who will prescribe the treatment. Package of care, HIV and STI screening, clinical services, routine screening, PEP initiation, follow-up to ensure that they are adhering, and also referral to other services not being offered in the healthcare facility. Next slide, please. So intervention approaches, we first of all, stakeholder engagement with the government, the state government, to let them know our plans, implementation plans, as well as to make sure that it rhymes with the policy of the government and that they're in the know of what we are planning to implement. Healthcare worker capacity building through virtual or physical method. So we try to make sure that we build their capacity in providing services to survivors that visit the healthcare in a non-judgmental way. Supportive supervisory visit in collaboration with the state. This is to ensure that services that are being implemented are in line with policy and they are in the know of what's happening across these facilities that we support. Data validation, data review meetings. Data validation happens on a monthly basis, review meetings as well, monthly, quarterly, so as to keep up and keep on track of what is required, validated data. Then routine data collection, technical assistance provision in areas where they're having challenges will come in as program staffs to ensure that they are in line. So the objective of the study, first of all, we assessed the sexual violence rate by age and by sex. We also checked PEP initiation rate by age and by sex, and identified barriers to timely PEP initiation. Next slide, please. So research method. It was a retrospective study looking at programmatic data collected within the period of October 2022 to September 2023. And we're looking at rape survivors who visited the facility within the 12-month period, thus a purposive sampling. This happened in Plateau State across 14 LGAs as at the time of review, although now we've expanded to all the LGAs in Plateau State. Descriptive data analysis was being used to look at the data being provided, and the instrument that was being used as well to collate data, the District Health Information System database, which is we were all familiar with. Next slide. So what were our findings? So out of the 137, about 80 of them, of the survivors, happened to be young adults within the age of 10 to 24 years. Making 58% in comparison to the other subpopulation. Now looking at the young adults, we now see female being highest, 94%, that's 75 in number, and against male, 6%, 5 in number. Next slide, please. So PEP uptake among the rape survivors, we can see among the females, it's really low, really bad, 75%. Out of 131 survivors, males as well, although when we look at absolute numbers, yes, the males, they are small, but yes, that's the rate. And there were a lot of reasons stated for not initiating on PEP on time, such as presenting, at the point of presentation, they were already PL HIVs, and 8 of them stated they had the incident way before they reported to the healthcare facility, and 11 of the females claimed no penetration, as well as the 1 male who didn't initiate on PEP. So looking at the distribution of rape cases and PEP uptake by age and sex, we can see that it's higher among the age band for the females, 25 to 29, down to less than 10. And also amongst the male is 20, 24, although we see it spiking around the 15 to 19 years of age. And we can see there is also gaps in PEP initiation. Next slide, please. So in conclusion, the study reveals that a disproportionate burden of sexual violence amongst the females is really high, 96%, particularly amongst the adolescent and young persons, out of which 79% of them received PEP, which is a very big issue, a very wide gap. Although from my being here at the conference, it has always been PrEP, 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 and no one is saying anything about PEP, about those who get to be raped and there's no form of support for them, be it within the community, thus targeting interventions for adolescents and young persons within the community. It's very key. Next slide, please. So what are my recommendations? Empowering community members through specialized training to lead targeted, culturally aware outreaches within the community. The strategy will help build public trust, and it will also make the community to own their innovation and ensure that it's successful. What are we looking at? Survivor mentorship program, empowering persons who have experienced sexual violence one way or the other to be community champions and also act as point of contact within the community. Persons tend to not know, okay, where do I go to in the healthcare facility? Which healthcare facility? Who do I meet? They will be able to assist with that. And they will be providing some form of health talks on sexual violence and the services they can access and where they can get it. Same thing, looking at age, peer support personnel. These young persons, when they get to the healthcare facility, they are uncomfortable. They don't know if this person that I'm going to meet knows my mom or my dad or my uncle, and they are scared and conscious of whether they should go or not. So therefore, they fall back on their friends in the community and carry out activities that they end up regretting. Next slide. So I want to use this opportunity to appreciate the survivors that shared their experiences, as well as the healthcare facility focal persons, the data persons for their hard work, APIN Public Health Initiative, as well as my co-authors, who some of them are here at the moment. Thank you so much.
Thank you, thank you, thank you. So you can take a seat back there. All right. So we'll take the second presenter, Dr. Abdulmuminu Isah. He's a senior lecturer, researcher, and a clinical pharmacist at the University of Nigeria. He has co-authored a number of papers and is mentoring a lot of people. So he's going to present the topic, assessing the willingness to recommend PrEP to HIV-negative partners by a person living with HIV in Nigeria. So over to you.
Good afternoon, everyone, and thank you for joining us today. On behalf of my co-authors, I want to present this work where we assessed the willingness of people living with HIV to recommend PrEP options to their sex partners, as well as the preferred one and the interest for what they want to do. In HIV response, we've observed that one of the best options out today towards the elimination of HIV/AIDS is prevention. And one preventive measure which has been shown to be successful is the use of pre-exposure prophylaxis. Next slide, please. But in all programs, in all interventions that you've seen, people talk about those who are exposed without thinking that the people living with HIV themselves have a role to play in increasing the uptake of these strategies. In Nigeria, we still have a very low uptake of PrEP. Even when we have the new lenacapavir, we don't have any center in Nigeria that offers it. We believe that by the time we are able to know if those living with HIV have a role to play, if they agree to recommend PrEP to their partners, then there could be a point of contact towards improving uptake of HIV/AIDS PrEP solutions. Next slide. So in this study, we had 3 main objectives. The first was to determine if people living with HIV were interested in recommending PrEP options to their partners. If yes, what type of option do they think is preferred between the oral and the long-acting injectables and even the parabolic ring? Beyond that, wanted to know what are the drivers, the factors that will increase this, that will determine this choice of recommending PrEP to their partners. So we conducted a study, next slide, a study that was cross-sectional in a north-central Nigerian city. We used a health facility that provides services to people living with HIV, and we randomly talked to 250 respondents based on a sample set calculation. Using a 13-item validated questionnaire, we sought those questions and had these issues that we mentioned earlier in the objectives. What was the willingness to recommend? What were the options that they preferred for their partners? And what are the factors that will influence these options? So using both descriptive and inferential statistics, we came out with our findings. Next slide. So we observed that most of our respondents were females. There were male respondents that were in this facility, but most of them did not provide consent to participate in the study. Most of them were 40 years as far as the age is concerned, and we observed that over 90% of all the respondents in the facility who were receiving care had virally suppressed load in terms of HIV viral load. And we saw, after asking, that will you be willing to recommend PrEP to your partner who is HIV negative? 75% said yes, that they will do that. And when we asked them which will be the most preferred option, almost 70% preferred the long-acting injectable as compared to the oral PrEP. For the male partners that we asked, none of them chose the parabolic ring as a preferred option for PrEP prevention. So what are the factors that influence these choices? Next slide, please. We observe that the most common factor that influenced the choice of preferring long-acting injectables over the oral was convenience. They observed that whether it is cabotegravir or the lenacapavir, having something once in a month or twice in a year provides more convenience to something that you have to do every day, or even if it is every month, like in the Department ring. We observed that they also talk about the issue of privacy, that they don't need to be going to the facility all the time to get their medications. And some talk about the issue of low pill burden when they use long-acting injectables. Of course, there's no pill burden at all. Next slide, please. We went further to ask what were the factors that influenced the choices of recommending PrEP to partners. We observed that those that said that they were willing to recommend PrEP to their partners were those who had prior support from their partners. Their partners are HIV-negative, they are living with HIV, but with the support that they've received from these partners, they were interested in recommending the PrEP options to their partners. And finally, we observed that those who had good knowledge of PrEP and HIV generally were almost 3 times more willing to recommend PrEP to their partners than those who did not have a good knowledge of HIV. Finally, we conclude. Next slide, please. We conclude that people living with HIV are willing to recommend PrEP to their partners, and that if you give them options, they will recommend the long-acting injectables to their partners. We now recommend that if at all we should give strategies, we should be involved in interventions that will improve uptake, then one key population that must be involved in this strategy is those people who are living with HIV. Let us not think that because they are not eligible for PrEP medications, they cannot play a role in improving the uptake of PrEP. Thank you very much for listening.
Thank you. Wonderful presentation. So we'll take our last presenter, Ms. Nancy Ruth. And she's going to talk on feasibility and acceptability of pharmacy-based collection of PrEP refill for female sex workers.
Good afternoon, everyone. Thank you very much to the organizers of this conference for inviting me to this conference. I'm delighted to talk about an intervention that we implemented in Zimbabwe, where we availed pharmacy-based PrEP refill collections for sex workers in Harare, Zimbabwe. That's where we conducted this. We conducted this study because female sex workers are at high risk of HIV, and their continuation on PrEP is suboptimal. We developed this intervention. We actually co-developed it with the aim of improving PrEP continuation amongst female sex workers by providing pharmacy-based collection of PrEP in their communities. We called this study TOPAZ, which means Together Optimizing PrEP Access in Zimbabwe. TOPAZ was nested in a nationally scaled key populations program. It's a very big population KP program in Zimbabwe. So in this presentation, I will report the results of a process evaluation. In the next slide, I give you details of the study. So we purposely selected 8 KP program outreach sites in Harare, and we randomized these 1-to-1 to the standard of care arm and to the TOPAZ intervention arm. So in the standard of care arm, sex workers were initiated on PrEP at the KP program clinics, and they would collect their PrEP refills at these same key KP program clinics. In the TOPAZ intervention arm, female sex workers were initiated on PrEP at KP program clinics, but they had a choice to either collect their refills at the KP program site where they are initiated, or opt for the TOPAZ intervention pharmacies where they would go and collect refills there. But they still had choice. If they wanted to remain in the KP program, they would remain. If they want to go to the TOPAZ intervention this time and go back to the program clinic for another refill, they were free to do so. So to keep key female sex workers in rhythm of collecting, can you go to the previous slide, please? So to make female sex workers get used to getting to pharmacies and getting their PrEP refills from there, they were offered a time-limited gift voucher. At month 1, at month 3, at month 6, there was no voucher at month 9 and 12. So in this intervention, pharmacists who participated there were trained in HIV testing by Ministry of Health. They were also trained by study staff on the protocol itself, how to implement it, and how to conduct PrEP refills and also gift vouchers. Pharmacists were given a once-off payment of $50 as recognition of their participation, and also dispensing fee of $1 for each refill that they administered. Next slide, please. So these are the methods that we used in this study. Study staff kept events log of what was happening in the implementation process. Any views from pharmacists, from female sex workers were recorded in the events log. Then the pharmacists themselves completed a self-administered questionnaire in which we assessed the feasibility and the acceptability of them administering pharmacy-based PrEP refills. We also held quarterly meetings with female sex worker and pharmacist advisory boards to understand their feedback on this implementation, what was going on well, what was going not so well. Participant observations were conducted at 6 pharmacies during implementation to understand the pharmacy environment in which female sex workers had collected their refills, and also observing social interactions between pharmacists, the sex workers, and other general customers. So participant observation data, events log data, and the events log data and pharmacist observation data, as well as data from the meetings with advisory boards, were analyzed thematically. Then data from the pharmacist questionnaire were analyzed descriptively in Stata. Then the interviews that we conducted with sex workers, pharmacists, and KP staff, we analyzed the data using rapid qualitative analysis. Next slide. I present the results in the next slide. So these are the characteristics of participants and the data that we collected. We spoke to 12 female sex workers, 13 pharmacy staff or pharmacists, and also the key populations. We talked to 5 staff. We conducted 20 observations at pharmacies, held 7 advisory board meetings quarterly from the study inception to the end. Then the events log was kept by study staff throughout the implementation. We found that across participants and across data collection methods, the TOPAS intervention was implemented with fidelity. Pharmacy refills were implemented as intended, and 99% of these refills were completed within window, and with participants were tested HIV negative. We also found that generally refills were conducted in a private and confidential way within the pharmacies, though there was only one pharmacy where we thought privacy was suboptimal. Incentives for habit formation were distributed to the recipients of PrEP refills as intended. Next slide, please. We also found that TOPAS was highly acceptable amongst pharmacists, KP staff, and female sex workers themselves. Pharmacists thought implementing this intervention, in particular HIV testing, training, and certification, was a very good professional development on their side, as it aligned well with their continued professional development as professionals. KP staff also expressed that the pharmacy-based PrEP refills were conducted in a very private and safe space for female sex workers, which likely promoted continued review at the pharmacies and also acceptability of the intervention. Sex workers themselves, they were happy to have reviews at the pharmacies. They felt the review process there was very convenient to them, service was quick, and the long opening hours of pharmacies allowed the flexibility that they needed as female sex workers, given their busy work schedules. They were also happy, the female sex workers, because pharmacy staff were friendly to them and they treated them with the respect that they deserved. As you can see from the figure, Topaz was highly acceptable even after the removal of the incentive at month 9 and month 12. We still have the Topaz intervention indicating high retention on PrEP, even across all the time points, as compared to the standard of care arm, where we, from month 3 onwards, we have 0% continuation. Next slide, please. Now the gift vouchers that were offered to the female sex workers, the female sex workers themselves appreciated the gift vouchers, and we discovered that they were effective for habit formation amongst the female sex workers, because female sex workers kept refilling their PrEP at the pharmacies even when the incentives were discontinued. Even when they knew there were no incentives, they kept going to the pharmacy to refill. For pharmacists, the incentives, the gift vouchers were acceptable to them because they were redeemed within the pharmacies for products within the pharmacies. So to them, it was good business. Then the pharmacists themselves, they got those incentives for participation and they perceived them as fair. However, they suggested that the dispensing fee be increased a bit in recognition of the time and effort they spent implementing the long review process that was involved. Though the Topaz intervention was acceptable, it was feasible, we found that pharmacists' workload went up during implementation of the intervention. So due to competing responsibilities, pharmacists were sometimes unavailable when sex workers turned up for their refills. We also experienced pharmacist attrition. A number of pharmacists resigned from their jobs during implementation of this intervention. We also noticed one isolated case of a female sex worker who sent a peer to collect refills on her behalf for month 1, month 3, and month 6. We referred her to the KP program for further management. Though we experienced funding cuts along the way, refills at the pharmacies were not disrupted. Female sex workers continued to refill at the pharmacies. However, the KP program activities were affected by funding cuts. Next slide, please. In conclusion, we found that pharmacy refills were feasible to deliver and they were acceptable to both female sex workers and pharmacists. And also providing the option of pharmacy refills was very convenient for female sex workers, and it promoted continued refill at the pharmacies. The incentives indeed resulted in habit formation amongst female sex workers. Importantly, PrEP refill continued beyond the incentive at month 9 and 12, which was good. We have no evidence from this study, however, that all these female sex workers who picked up PrEP refills indeed took up their medication as expected. Therefore, we recommend in future some studies that include evaluation or actually studies that consider PrEP adherence measures such as biomarker testing to see if they are really taking their medication, and also evaluating to see if incentives really result in continued PrEP uptake. So there's also, go back a bit, so there's also need to evaluate other forms of delivery of PrEP or other different types of PrEP that we can also evaluate to see if they are acceptable in the pharmacy, like the recently approved long-acting injectables. We could try them as well to see how they do in pharmacies. Last slide. I acknowledge study participants. I acknowledge the implementing partners and the co-authors to this study. Thank you.
Thank you, thank you. So we started from PEP to willingness to recommend PrEP, and now to PrEP refill at the pharmacy. All right, excellent presentation. So are there any questions, clarifications? We can take 5. We can direct to the speaker.
All right. Thank you very much. I want to appreciate all the speakers. Well done for the great job. So my questions go to the last speaker. I'm sorry, I didn't get your name, lady from Zimbabwe. I noticed that you kept mentioning pharmacists, and I want to find out, are they community pharmacists or pharmacists that practice in a private hospital or facility? Just to be clear, that's the first question. Are they community? Because, for instance, in Nigeria, we have PPMV, we have community pharmacists, and so on. Then the second question is about seroconversion. Is there any point in time that any of the people on PrEP, any of the ladies or sex workers on PrEP, seroconvert? Right? Because I know you have to be doing the routine HTS testing at each visit, right? Is there any documentation of seroconversion? So the third question is about the scalability. I didn't quite get the number of regions where this happened in Zimbabwe, whether it's within the urban or rural or semi-urban, and then is this something that you think can be scaled, right, to reach more sex workers? Thank you.
Thank you. Any other?
Hello. Hello. Yeah. Thank you very much for the presentation. The PrEP refill at the pharmacies or with the pharmacist. It is good to see that at the end of the 12-month period, we have about 43% of the participants still coming for refill. I wanted to find out whether your team really looked at the impact of the gift voucher, the money incentive on the participation, because once there is some form of incentive to have participants coming back again over a period. And that will also motivate others to come for that particular service. The other concern or question is how the token to the pharmacist was going to impact delivery of service. As you mentioned, along the line, they were requesting for a top-up in the token. So when there is no token and with this workload, did we check to see whether pharmacists or pharmacies were going to be willing and ready to provide this service, which was bringing on additional burden. And in all of these, to look at the third, in the fact that we are having dwindling funding for such things, how is this going to have impact on the pharmacy as a refill for sex workers? Very much.
Thank you. Is there any other? All right.
Hi. So my question goes to the second presenter. I wanted to know if for the small population that were unwilling to recommend PrEP to their partners, did you get any reasons, and did any of them include difficulty in disclosing their status?
All right, so I think you can take this, and then we'll come for the second round. You have a microphone with you?
Right. Hello. Thank you very much, the lady who asked first. But I think, sorry, I missed your first question. I'll respond to the second and last. Well, I'll come back to you. You repeat. Sorry about that. You talked about whether any of the participants in this study seroconverted during the implementation. No, we did not have any participant who tested HIV positive during the duration. This study ran for 12 months. It was just a pilot. So when we implemented this study, we are not working on our own in isolation. We are working with the PeP program. That's the mother, that's the house where this program is housed. So they help us with the other management issues related to PrEP, to someone who is on PrEP. So we did not have any seroconverter. This study took place in Harare. Harare is the capital city of Zimbabwe. It was in 4 suburbs, to total of 8 suburbs, 4 per arm. Okay. Then the other question, I didn't quite get it. Sorry.
Okay, thank you. So my name is Dr. Bumi Amao from APIN Public Health Initiative in Nigeria. So
I can't hear you.
So I asked whether the pharmacists that were used were facility-based, right? Or are they in the community? Do they have their own outfit within the community? Just to be clear, because you mentioned pharmacists. I'm not sure whether they are within the facility or they have their own practice in the community.
Yeah. So these were private pharmacies within the communities, in the locals, in these suburbs where we were implementing TOPAs. We selected pharmacies who were willing to participate, knowing what was involved. Then those were the pharmacies involved. Then coming to him, he talked about the issue of gift vouchers and participation, how gift vouchers were likely to, the impact that the gift vouchers were likely to have on participants. Yes, so in this study, we recruited up to 100. We had a limit in terms of how many female sex workers we would recruit in the intervention arm, as well as in the standard of care arm, for the purposes of this study. So we only recruited up to 100 participants, and those were the participants who kept coming to refill at the pharmacies. And these incentives were meant to nudge these female sex workers at the beginning of the intervention. Then when we stopped the incentives, that's when we would now see how someone would, if they would continue coming in their numbers or not. So from the qualitative work that we did, we discovered that for female sex workers, the incentive was just another thing or another issue. What motivated the most was the convenience of a local pharmacy, given the costs of traveling to the KP program in town, and also the KP program outreach clinics would come to the communities, but not in a regular way. So incentive was something else, but the convenience was what they wanted most. They were interested in most. Then how likely was this? You were talking about dwindling pharma funds, and if the pharmacists were willing to implement this with the little incentives that we provided. What we discovered was that these pharmacists themselves, they were not so much into the incentive. What they were happy about was that this program actually brought them more customers. Female sex workers who didn't come to the pharmacies that often, by the end of the program, they were actually coming to pharmacies to ask for other services. So they were, apart from the incentive, they were actually happy to say, our customer base has expanded, and they were actually willing to partner with Ministry of Health. That also showed some interest to take the route of pharmacy-based PrEP.
All right, thank you. We just have 3 minutes, so.
Okay, so factors that we observed affected those that did not want to recommend the PrEP were essentially 3. 1, those who were virally suppressed believed that there was no need for PrEP because they believe in the U is equal to U. The second factor is that they believe that if it to be provided, it will not be free of charge in the facilities, like the drugs are for them, and they believe that it is expensive and they could not afford it. The third factor was that those that on their own were not virally suppressed, we observed that when we checked the database for the percentage of their adherence, all of them were below 80% of their own adherence to refill appointments in the facilities. So we believe that that also affected their reason for not recommending PrEP for their partners. Thank you.
Thank you. We just have under 1 minute. Is there any pressing question, any burning question that if you don't ask, the whole world will collapse? All right. So there's no such question.
There's a hand at the back.
Oh, where is it? Oh, okay.
Thank you. My name is Rafael from Tanzania, and my question is directed to the last presenter. Sorry if I caught you well. You said that there were incentives to these pharmacists based on the people they have provided services to. And experience-wise, when incentives is introduced on service provision, it actually attracts data fraud. So I was interested to know, how did you monitor these frauds? Because if they are being paid based on what and how many people they have served, then they might in one way or the other trigger these data so that they can get more incentive. Thank you.
Okay. Okay, thank you for that question. This PrEP refill dispensing fee of $1 was given to the pharmacists for each refill that they conducted. And if maybe you didn't quite get that aspect, to say each community, each suburb where we had toppers running, we had 25 participants or female sex workers, a maximum of 25, going to a specific pharmacy. And all of them in total, they were 100. So we had 4 pharmacies. And each pharmacy would take up to 25 participants who come and refill month 1 until month 12 at that particular pharmacy. So he would serve those same 25 participants who are coming. And each time they refill, he gets an incentive of, he gets $1. So it was not like open to everyone who could come. It was a pilot. We really wanted to find out what goes on in pharmacies. So there was no room for the pharmacies to save more. It was the same clients coming back.
Thank you very much. So most of the questions went to just one particular person. Maybe, Lizzie, is there anything that you want to add? Yes.
So, yes, like I said earlier during my presentation, it's PrEP, PrEP, PrEP. No one talking about the PEP anymore. And it's really vital, especially for, there are instances where persons get to be exposed, engage in, especially within the young ones, high-risk activity, and they don't know where to get help from. You hear things like, anyway, in my experience, I heard of some students claim that they can take, is it Teams or Sprite, and some will say if you jump up and down, it will come out and you're good. So these are things they get to hear within the community from their peers. That's why we are proposing that the government, we should have like a stakeholder engagement with our government, also with the stakeholders, the primary stakeholders, that's the young ones, to see what can we do to help them within the community. That's really key. And to also make the government see need to bring about policies to help them, especially in this area. And as we are thinking about injectable PrEP, I think it's about time we start thinking about injectable PEP, so that, because pill burden is an issue. I don't like drugs. Malaria treatment, trust me, first 2, 3 days, the third day, maybe morning, night, I'm not taking it. So this is also an issue, and it would be really great if that is considered. Thank you so much.
Thank you. So each one of us is expected to have a take-home message. This is my take-home message. That PLHIV, who have supportive partners, they are willing to recommend PrEP for those one. If person is living with HIV and your partner is supporting you, those PLHIV are willing to recommend what? PrEP to their partners. You have to be a supporting partner. That's my take home. I expect each one of you to have your take home. Thank you very much for this session. It's been a wonderful session.